Okay, so I have the pleasure of presenting on combining ablation with other interventional oncologic methods and the various adjuvants to obtain better results of therapy. And similar to Costi, I will divulge my research support from multiple industry and governmental sources. Basically, the message that I'm going to be stressing here is that if we take tumor ablation in its many different varieties and combine it with other therapies such as chemoembolization or CERT, as was just presented elegantly by Dr. Liu, together, we are going to see that we get much better results. And this was pretty obvious from one of the most early initial meta-analyses in 2013, where 1 year and 5 year survival actually was improved just by combining RF ablation and chemoembolization for patients with colorectal and HCC disease. It turns out that there was actually an initial randomized trial that was published in 2012 in radiology, Chinese study that showed that the combination of chemoembolization with RFA caused better overall survival and disease-free survival for all comers, all patients, over RF alone. And most importantly in that study, the patients that tended to get the best results were the ones that, as Costi had pointed out, were the most difficult to treat with RF ablation alone. The tumors ranging from 3.1 to 5 centimeters, as tumors 3 centimeters or less are well treated with thermal ablation, be it radiofrequency and microwave. And other studies, such as an Italian study, confirmed that you got much less local recurrence and similar, if not better, survival from combination therapy. It turns out that there's been a very nice, and this is one of the 2 studies that I encourage everybody to take a peek at. There's been a very nice meta-analysis of what is now 55 randomized controlled trials out there for all different types of chemo embolization and radioembolization alone, and with various adjuvant therapies, including ablation. And we can clearly see in this survival model that the combination of chemoembolization with tumor ablation ended up with the best overall survival and the best objective response, as we can see here. TACE plus ablation gave a better result than TACE plus radiotherapy or chemoembolization by itself for unresectable hepatocellular carcinoma. Interesting enough, this is another paper that I encourage everybody to take a look at. There is a paper out there by Lan et al. In Medicine from 2016, where they looked at randomized control trials, not only of interventional oncologic therapies such as TACE and ablation, but also hepatic resection. And what they found here, as we can see, if we look at the 1 year, 3 year, and 5 year survival rates, the TACE plus radiofrequency ablation, which was the dominant methodology in those days, far outperformed in terms of the cumulative probability of survival hepatic resection when looking at this meta-analysis. And the others have looked more recently at matched case control studies and have at least found similar results between surgical resection and combination therapy. And the message, therefore, that I wish to provide the august audience is the fact that combination therapy is going to give us the best shot at our making interventional oncology the 4th pillar of cancer care. And if we think about it, anytime one goes to war, we don't just send out the Air Force or the Navy. The best results that we're going to get to win the war against cancer is by using all of our tools, which will include transcatheter and percutaneous ablation therapies simultaneously. Now I'm going to spend a little bit of time talking about these combined therapies, particularly focusing on HCC, and ask several of the basic scientific questions. As many or most of you know, I am a big proponent in not only being a clinical physician, but in also trying to better understand and being the bridge translationally to understand what we're doing and how we're doing it to get the best results. And therefore, we need to ask several questions. Why we get better results with combination therapies, how to best get that result, and can we do it better? And we'll discuss some of the future combinations. So let's go to the rationale. And it turns out if we want optimal ablation,
is the paragraph?
Kosti, please mute. If we look at optimal ablation, again, we want to send the Air Force, the Navy, and the Army. And the way to do that is to destroy some of the tumor by as much as we can using heat, microwave, RF. We want to use chemo drugs to try to kill some more. And we need to acknowledge that chemoembolization is not just the chemo, but it's also the hypoxia of the embolization. And all of those can synergistically work together to get optimal ablation. And one of the reasons that's true is if we look at from an ablation perspective, and I apologize, as most of you know, I'm very ablation dominant, but if we look at the ablations, we know that there's a negative influence of blood flow, that blood vessels will take away some of the heat sink effect and make smaller zones of ablation than what we would ideally like. And therefore, if we can get rid of that blood flow, which was shown very early in 2000 by Rossi in radiology, just by doing bland embolization, we can potentially get much better results of our ablation by having more heat be inside the tumor, and we therefore get much greater volumes of tumor ablation. And therefore, it would be no surprise that the combination therapy would have less recurrence than just tumor ablation alone. One can actually potentially even get rid of some of the blood flow, not by a transarterial therapy, but by giving some of the drugs that we like to, or at least in the past have given for HCC, the antiangiogenics, such as sorafenib. This was a nice study done in our laboratory by Antoine Hakime from France, where he gave sorafenib, and we documented that the tumors had less of these little wiggly lines on the immunohistochemistry, meaning blood vessels. And with the reduction in blood vessels, we were able to get much greater zones of ablation for the combined RF and sorafenib. And it turns out that there are studies out there, such as the one by Giorgio et al., where the combination of sorafenib, an antiangiogenic, and RF ablation got better survival than just sorafenib alone, which would be no surprise. Again, the issues of whether or not we want to do this by adding the transarterial therapy or just giving a drug will be an issue that we need to discuss. But there's no question that getting rid of some of the blood flow is going to improve our ablation. Let's look at the potential benefits of the chemo side of chemoembolization. And we need to acknowledge that when we heat, and we cause an ablation, basically we're only using temperatures that are 50 degrees and higher that coagulate the tissue in approximately 4 to 6 minutes. The reason being that temperatures slightly lower than 50 degrees, although they can cause some cellular damage, and we'll look at that in just a minute, most of it is reversible unless you heat for very long periods of time, such as 45 minutes and beyond, which is often way too long for what we would like to accomplish. And therefore, the question becomes, can we, by giving chemotherapy, increase the volume of the zone of the ablation by taking advantages of temperatures that are lower than 50 degrees and are much larger in terms of area, ranging down to, let's say, 47 or even 45 degrees? And the answer is that we can. These are some of the original studies that we performed now over 15 years ago, where we gave doxorubicin in liposomes, Doxil, and we'll get into the concept of liposomes a little bit later. And one can see here in 2 tumors from an animal study that RF alone gave a certain amount of ablation here, but there is an intense zone of uptake. This is not inflammation. This is an intense zone of the red doxorubicin being taken up by these tumors in the area immediately surrounding the zone of ablation, and that causes oxidative cell stress, as this band shows of the immunohistochemistry, which induces apoptosis, programmed cell death. And therefore, it's no surprise that if we combine tumor ablation with chemotherapy, and this was given as long circulating products, liposomal doxorubicin IV, we get the much better survival curves in animals than we achieved by either therapy alone. And clinical studies have borne out the potential benefit of the combined approach. Here we see a CT immediately post-ablation. We gave a single dose of liposomal doxorubicin, and 3 weeks later we can see a much larger zone of killed cells due to the interaction between the drug and the heat that was not enough to kill the tumor by itself, but it damaged the cells enough to allow the doxorubicin to do its job. And this is one of the our nicest cases where we performed RF ablation of an 8 centimeter HCC in a Chinese patient. And after the original RF ablation, we can see clear areas of viability over here and over here. And we gave, therefore, an ampule of liposomal doxorubicin and demonstrated that the liposomal doxorubicin over 2 weeks killed out this triangle and a large wedge of the increased zone of ablation, increase of viable tumor, and only had this small area that we needed to clean up. So this patient received 2 RF ablations and in between 1 liposomal doxorubicin therapy. By the way, we can see that there was a vessel and viable tumor surrounding the vessel that was killed by the additional adding of the liposomal doxorubicin. And if we look at 4-year follow-up with no other therapy other than that 1 combined course of RF ablation and the doxorubicin, we can definitely see that there was no evidence of tumor at 4 years. Now, we're talking about 2 therapies, giving thermal ablation and chemoembolization. When do we administer? Who goes first? And what are the advantages of each potential methodology? Well, it turns out that there is a nice, again, Chinese paper in JVAR from 2019, where they looked at whether or not if the 2 therapies, TACE and RF, were given within 30 days together, which they called the sequential group, or the delayed group where the patients got therapies, but they were further than 30 days apart, and giving the 2 sequentially, meaning within 30 days of each other, had much better survival for both small and large tumors. It turns out we've actually looked in our laboratory at the question of whether or not you do the TACE and then immediately followed by RF, or RF and immediately followed TACE. And if one is interested in creating the largest zone of coagulation, the TACE needs to go first because we need to get the embolic phenomena. We need to get rid of the blood flow so that we can get the greater heat retention and the larger zones of coagulation. It needs to be noted, though, that some people, this is from Damien Dupuy in Rhode Island, have used RF and microwave ablation to destroy a large portion of the tumor, and then given chemoembolization in concentrated fashion to go to the regions that they were unable to clean up, similar to the approach we used with the liposomal doxorubicin. Similar findings were done with RF and DebTase by Riccardo Lencioni, who used the inflammatory zone surrounding RF ablation to get high concentrations of DebTase. Okay, now one of the reasons that Leo originally had patients with combination therapy within 30 days and patients who had therapy not within 30 days, meaning longer, is that if we're talking about HCC, then we need to acknowledge that these patients tend to form multiple tumors, and over the natural course of history of their disease, they will sometimes present with limited focal disease, in which case ablation may be most appropriate. And if that is successful, then larger tumors may eventually, or more aggressive tumors may eventually crop up, which may be better amenable to transarterial therapy. By the way, the opposite is also true, that theoretically the patient could present originally with very large tumors that if kept under control with chemoembolization, then smaller tumors could pop up and be amenable to tumor ablation. And therefore, selecting the appropriate therapy needs to be determined by the presentation of disease at that time. Percutaneous for limited disease, tumors less than 3 centimeters. If the tumors are bigger than 5 centimeters, then transcatheter is definitely the way to go, with CERT being something that certainly should be thought of, as Dr. Leo has pointed out. And combination therapies are likely to provide the best outcome in many cases, particularly the 3 to 5 centimeter tumors. Okay, can we do it better? Future combinations, and this is where a lot of research is going on. I'll just tickle people's fancy with a couple of examples. And the first that we're going to go back to is the concept of the liposome. I had shown evidence that giving liposomal therapy, the long circulating liposomes, had pretty good results with better animal survival and better clinical results. We need to acknowledge that those liposomes are basically a delivery packet that, if modified, can last in the blood supply for a very long period of time and concentrate drugs such as doxorubicin within them. They're actually, and the reason that might be potentially useful, as we showed approximately 15 years ago, is that if one RF ablates a tumor and then gives liposomal doxorubicin, these are 2 tumors from the same rat, and this one had RF, this one didn't, and we can see that the liposomal particles go much greater to a tumor that has actually undergone ablation. There's another class of liposomes, and those are heat-sensitive liposomes. And essentially the strategy there would be to have them burst and deliver their content during a microwave ablation, for example, and deliver larger amounts of doxorubicin or other products precisely during heating. And that received a large attention in terms of potential. And indeed, there was a very nice randomized trial that included centers in Hong Kong and China, as well as Italy. And unfortunately, as the study was initially designed, they did not see any benefit to giving the heat-induced liposomes. And of course, the question now becomes, why? If we're also sanguine, if we're also very hyped up about potentially getting great results, why didn't they get good results? And that may actually have to do with the type of liposome that was used, and let's see why. I actually performed a study here in Jerusalem where we had to create our own thermally sensitive liposomes and our own long circulating liposomes because the companies didn't want to go head to head with each other. And what we found is that when RF was combined with long circulating doxorubicin liposomes, the tumors were well controlled, whereas there was only a very modest decrease in tumor growth and to increase in tumor control when we use the heat-sensitive liposomes. And we actually believe that we've come up with understanding why, and that has to do with looking at the amount of doxorubicin that's actually in the tumors. If we look at heat-sensitive liposomes, you actually get the greatest amount of drug in those tumors for any possibility at 1 hour, because you burst the liposomes and deposit high concentrations of liposomes. However, the problem is that that doxorubicin doesn't stay in the tumor. It washes out very, very rapidly, so that by 24 hours, there's very little drug. On the other hand, if one uses a long circulating liposome, then the drug will slowly and steadily increase its concentration and be much more effective at 72 hours. And we concluded from those pharmacokinetics, similar to the Greek Aesop's fable, that the slow tortoise, getting the drug slowly there, can beat out the speedy hare if the hare is not careful and is not there at the right time. It actually turns out that this trial the heat trial did look at subgroups, and they found that patients that were treated with tumor ablation for more than 45 minutes actually did get slightly better survival, which is no surprise because they were getting the synergy over that hour with those very damaged cells that I had discussed earlier. Okay. Can we change the drug? It turns out that people are working on using other drugs such as Paclitaxel and getting better results by combining the therapy. The rationale being that Paclitaxel gives much greater amounts of apoptosis in combination with radiofrequency compared to liposomal doxorubicin. We need to acknowledge that beyond the area of apoptosis, we start activating other things such as heat shock proteins, and if we can, which actually prevent the tumors from their cells from dying, and if we can knock out the heat shock protein with drugs such as liposomal quercetin, we can potentially get much greater zones of ablation than RF alone. And indeed, it would be no surprise that if we combine two mechanisms, getting apoptosis from doxorubicin and quercetin knocking out heat shock proteins with RF, that will get much better survival as shown in this animal study than the others. What about combining tumor ablation with other adjuvants such as radiation? And it turns out that there is a synergy to be found there. And again, if we stain and combine tumor thermal ablation with radiation, we will see, again, much greater oxidative and nitrosative damage, meaning that they are synergistically working from free radical mechanisms to create greater amounts of apoptosis. And therefore, some of the best survival in our animal models has been when we've combined radiofrequency ablation with radiation therapy. And it goes without saying that all of the slides and material that I've discussed in terms of combining ablation with chemoembolization could easily be accomplished by combining it with radioembolization with SIRT, as mentioned by Dr. Liu. We've actually in the past used a CyberKnife to get rid of portal vein thrombosis and then treat the rest of the tumor with radiofrequency ablation. I'm going to take a pause for literally 10 seconds. I'll be back in 10 seconds. 1 second. I'm terribly sorry. All the electricity turns off here automatically at 4 o'clock. But I'm now, can you guys hear me now?
Yes.
Can people hear me?
Yes,
okay.
yes.
So now let's deal with the combination. The last set of combinations that I want to deal with are the most cutting edge therapies that are now out there in immuno-oncology. And the question is, can we combine IO therapies with immuno-oncology to improve their abscopic effects? And what I mean by abscopic effects are distant effects that occur far away from the area that we ablate. And there are case reports, for example, this one here from the Korean group, where a renal tumor was successfully ablated, and it was acknowledged that there was a small solitary lung metastasis. No therapy was given, and 7 months later, that tumor disappeared. So abscopal effects, something that was done for the RF, presumably affected a distant tumor. And we occasionally see spontaneous regression, but it almost never happens by itself. One of the interesting things, if we look at the cells surrounding the ablation, is that there are antigen-presenting cells, APCs, in the area surrounding the tumor ablation, suggesting that we could amplify the immune mechanisms. And indeed, it's been shown both with thermal ablation, and this is a nice example from cryoablation. I purposely chose this because it's from Kosti's center at Memorial Sloan Kettering, that if one gives checkpoint inhibitors, which are one of the range of the immune oncologic drugs that will allow tumors to be recognized better by the native immune system, if one gives those checkpoint inhibitors with cryoablation, you get much greater infiltration of lymphocytes and T cells particularly, and that is associated, the combination therapy is associated with reduced tumor growth and better tumor-free survival. And if we look with thermal ablation, there's a nice study going on at the NIH combining RF ablation with these checkpoint inhibitors. And here, this was a gigantic 10.2 centimeter tumor, and the checkpoint inhibitor and ablation were given, and the tumor shrank to 4.8 centimeters. And we can see lots of these extra blue dots in here. And these blue-purple dots represent infiltrating lymphocytes. And with the higher doses of the checkpoint inhibitors, they get much better responses in terms of the immune response with RF ablation. And it turns out that there are multiple other ways that we can combine thermal ablation with activation of the immune system. You can use co-stimulation, as the Japanese group used in VX2 tumors with OK432. One can use vaccines for amplifying the immune system in combination with tumor ablation. And it's no surprise that transarterial therapy also can induce immunomodulation and gets the immune system up and running, particularly Ronnie Averture at MD Anderson has shown the T cells that are up there as well. And if you have activated T cells with your chemoembolization, you get a much better survival from chemoembolization. And it turns out that there are over 100 clinical studies. If you go to tumor ablation and immune in clinicaltrials.gov, looking at all different types of ablative modalities, including microwave, targeting a whole host of different immune cells and different tumor types. And hopefully in the near future, there'll be some pretty good data out there in terms of what types of combinations, which types of ablation devices and transarterial therapies will be best in combination with which drugs for which tumors and clinical sites. So in conclusion, I'd like to point out there's no doubt that combination adjuvant strategies, they really offer a significant promise for improving interventional oncologic therapies, and we really have something to bring to the table. Particularly in the field of immuno-oncology. Best results, of course, will only be obtained if we match the adjuvants and the timing of those adjuvants to the mechanisms that are out there, again, acknowledging that there are thermal and hypoxic mechanisms out there, as well as immunologic. And those will be different in different specific clinical scenarios. And obviously, I'm a big proponent of further research to better delineate what we will achieve in the clinic and translating from the laboratory. And I hope that I can entice many, if not all of you, to get involved in those efforts. And I need to thank my Israeli team, my European collaborators, and my Boston team. Thank you very much.